Welcome to the Migraine Treatment Guide podcast, where we explore what really causes chronic migraines and headaches and the full range of treatments available today. Each episode breaks down the medical research and real patient experiences to help those living with chronic head pain understand their options and find a path toward lasting relief.
You know, when we usually talk about hormone-related migraines, there's this underlying assumption that we are entirely dealing with an issue of chemistry.
Right, like it's all just invisible molecules.
Exactly. We tend to picture this very abstract chemical process, specifically like a drop in estrogen that's somehow affecting the pain processing pathways deep inside the brain.
Yeah, that's the standard narrative.
Right, and you've probably heard this standard explanation, you know? The hormones drop, the brain gets angry, and bam, you get a headache.
It's what everyone is told.
But I mean, what if we told you that chemical equation is really only half the story?
It's a pretty big paradigm shift.
It really is. So welcome to the deep dive. Today we are exploring this really fascinating medical document compiled by Dr. Adam Lowenstein, who's a physician at the Migraine Surgery Specialty Center.
And it's such an important document, honestly.
Yeah, and our mission today is to uncover something that gets almost no attention in standard headache clinics. Like, we're looking at the hidden physical, mechanical triggers behind hormone-related migraines.
Because it's a critical shift in perspective, right? It is just remarkably common to stop the investigation right there at the chemical level.
Like, oh, your estrogen dropped, here's a pill.
Exactly. But stopping there leaves a lot of people without real answers. What we are really talking about today is how vascular changes and fluid retention literally, physically crush the peripheral nerves in your head and neck.
Okay, let's unpack this. Because if hormones are circulating everywhere in your body, like literally swimming through your entire bloodstream from your toes to your scalp.
Yeah, they go everywhere.
Right. So why does the pain of a menstrual migraine almost always seem to bottleneck in the exact same spot, like right above the eyebrow, or specifically at the base of the skull? If it's just a systemic chemical issue floating through the blood, I mean, why is the pain so hyper-localized to these specific square inches of the head?
That is exactly the right question to ask, and it completely validates the need to look beyond just standard blood tests, you know? What this deep dive will reveal is how the structural physical anatomy of your head interacts with those invisible chemical swings.
The actual architecture of the face.
Yeah, we're talking about physical spaces, little anatomical tunnels, and, well, what happens when they get too crowded?
And this matters so much for you listening, because whether you suffer from cyclical headaches yourself, or maybe you have a partner or a friend who does.
It's just so common.
Extremely common. Or even if you just love a really good medical puzzle, understanding this structural layer completely changes how we think about treating chronic pain.
It really does.
It takes it from this mysterious, invisible brain chemistry thing to a very tangible physical problem.
Exactly. So let's look at the physical reality of what estrogen and progesterone actually do to your tissues.
Because they're not just doing reproductive stuff.
No, not at all. These aren't just reproductive hormones that stay in the reproductive system. They have receptors all over your body,
Right.
including the blood vessel walls and the connective tissues that actually surround the nerves in your face and neck.
Let's start with estrogen, I think, because most of us know estrogen is generally protective for your cardiovascular health during, your reproductive years.
All right, it's great for the heart.
Yeah, and a big reason for that is estrogen naturally relaxes the smooth muscle lining your blood vessels. It keeps the walls of your arteries supple, allowing blood to just flow easily.
It's like a constant calming signal to the blood vessels.
Exactly. But when estrogen levels drop sharply, like they predictably do right before your period, that relaxing effect just vanishes.
Gone. And that sudden loss of relaxation is where the mechanical problem begins. The small arteries in your scalp and your face suddenly become highly reactive.
Because they don't have that estrogen telling them to chill out anymore.
Right. Because they've lost that steady, relaxing signal, they start dilating and constricting erratically. Now, I want you to picture a tiny blood vessel that travels right alongside a sensory nerve in your forehead.
Okay, I'm picturing it.
Normally, that blood vessel is what we'd call a loose neighbor.
A loose neighbor, I like that.
Yeah, it minds its own business, quietly doing its job. But when estrogen drops, that vessel loses its structural discipline. It swells, it gets reactive, and suddenly it becomes a very tight neighbor.
Oh, man.
With every single heartbeat, that swollen, throbbing vessel is applying rhythmic, physical pressure directly onto the nerve right next to it.
So you're literally feeling the pulse of your own artery beating against a sensory nerve.
Yes.
That explains the throbbing sensation perfectly. I mean, it makes so much sense. But it's not just the blood vessels acting up, is it?
No, it's not.
Because estrogen isn't acting alone here.
Yeah.
We also have to factor in progesterone.
Right. At the exact same time, the vascular tone is going haywire from the estrogen drop. Progesterone and its downstream effects are stepping into the spotlight. Well, progesterone influences a hormone called aldosterone, which basically tells your kidneys to hold on to sodium.
Okay.
And wherever sodium goes, water follows. This is the physiological mechanism behind that classic, completely normal premenstrual bloating that, so many people experience.
The famous water weight. But we usually think of that in terms of, like, our jeans feeling tight around the waist, or maybe breast tenderness.
Yeah.
We don't typically think about our forehead bloating.
No, we don't, but it does. That same fluid shift happens in the soft tissues and the fascial planes all over your body, including your forehead, your temples, and the posterior scalp.
Wow.
And when this fluid builds up in the tissue directly surrounding a nerve, it creates something called perineural edema.
Perineural edema. Let me break that down.
Go for it.
Simply put, peri means around, and neural means nerve. So it's tissue swelling immediately encasing the nerve itself.
Exactly.
So it's like trying to run a garden hose through a tight PVC pipe, but suddenly the hose swells up with extra water pressure from the inside.
Right.
And the inside of the pipe is shrinking from fluid retention at the exact same time.
Yeah.
The nerve is literally trapped in the middle of this anatomical vice grip.
That is a perfect way to visualize it. What's fascinating here is that these two mechanisms, the vascular engorgement pushing from one side and the tissue fluid retention squeezing from the other, they happen together.
At the exact same time.
During the exact same hormonal window. That dual squeeze is a huge part of why hormone-related migraines feel so incredibly intense, and frankly, why they are historically so hard to treat.
Because it's a physical crush.
You aren't just dealing with a stray chemical signal. You are dealing with a nerve being physically compressed from two different directions simultaneously.
Okay, so if the swelling is the underlying mechanism, the location has to be the variable, right?
How do you mean?
Because if my body is retaining water everywhere and my blood vessels are getting reactive all over, why don't I get a migraine in my arm or my back? Why is it always the head?
Yes. Because it comes down to the specific anatomical architecture of the head and neck. The sensory nerves we were talking about in the face and scalp, they don't just float freely.
They aren't just swimming around.
No, they travel through very specific anatomic tunnels. And crucially, these tunnels are bounded by fascia and muscle, not bone.
Okay, wait, let's pause there. Why does the not bone part matter so much in this context?
Well, because bone doesn't swell.
Oh, right.
If a tunnel is completely enclosed by bone, it's rigid. But when a tunnel is made of dense muscle and fascia, which is that tough web-like connective tissue wrapping our muscles, it can get thickened and engorged with fluid.
So it puffs up.
Yeah. When fascia and muscle retain water, they swell inward, choking off the empty space inside the tunnel. And these specific tunnels in the head have essentially zero extra capacity to accommodate that extra fluid.
So any inward swelling immediately hits the nerve.
Instantly.
Let's map this out for the listener so they can really picture it. Let's start with the front of the head, like the classic forehead migraine.
Sure. Let's look at the frontal region. You have two main nerves here, the superorbital and supratrochlear nerves. They exit through these tiny little notches right above your eyebrow. To get to the surface of your skin, they have to weave directly through the corrugator and frontalis muscles.
Which are the exact muscles you use to frown or raise your eyebrows, right?
Exactly those ones.
So when that premenstrual fluid shift happens, the frowning muscle gets slightly waterlogged, and that specific exit point above the eyebrow literally swells shut around the nerve.
Precisely. That swelling directly narrows the exit point. It's why patients will frequently describe a very sharp, specific pain and pressure right behind or just above the eyebrow.
It's so localized.
And interestingly, if you look closely, you can sometimes even see it.
Wait, really?
Yeah, there will be visible puffiness in that exact area during that specific window of their cycle.
That is wild. But wait, I have to push back slightly here to make sure we're totally tracking.
Sure.
My arms are full of muscles and fascia. My legs are full of fascia. If I'm retaining water systemically, why don't my elbows or my shins get migraines? What makes these specific tunnels in the head so uniquely vulnerable compared to the rest of the body?
It's a great point of comparison. It's basically because The nerves in your arms and legs generally travel through much larger compartments. They have a bit more give.
Extra space.
Right, there's literal breathing room. But these specific areas in the head are classic migraine trigger sites, well recognized in peripheral nerve surgery, precisely because they lack that extra space.
They're just too tight to begin with.
Exactly. The superorbital nerves, or the greater occipital nerve at the back of the head, they're sensory nerves crammed into tiny, high-traffic intersections. There is literally no room to spare.
So they are uniquely set up to fail if there's even a millimeter of extra swelling.
Unfortunately, yes.
Let's look at the back of the head then, because I know a lot of people who don't get the forehead pain, but they get this unbearable throbbing pain right at the base of the skull.
Yes, the posterior scalp and neck. The main player here is the greater occipital nerve.
Okay.
To reach the scalp, it has to travel through a thick, dense muscle called the semispinalis capitis, and then pierce through the trapezius fascia right at the base of your skull.
That sounds like a lot of tissue to get through.
It is. So when hormone-driven fluid thickens those tissue planes, the space gets very tight. But here is the real kicker.
Oh.
The occipital artery actually crosses right over the nerve at almost this exact same bottleneck.
Oh, wow. So you have the muscle swelling from fluid retention on one side and the artery crossing directly over it on the other side.
Exactly. So when those hormone-driven vascular changes cause that crossing artery to swell and pulse, it's beating directly against a nerve that is already being squeezed by waterlogged muscle.
Ouch.
Yeah. That structural collision creates that intense, throbbing band of pressure at the base of the skull. And we also see a very similar mechanism happen at the temples with another nerve called the zygomaticotemporal nerve.
Causing that classic temple headache.
Hey.
It's honestly a marvel of engineering when things work, but it's kind of terrifying to visualize when things swell.
It really is.
So we've established the anatomy. We have these specific, vulnerable pinch points above the brow, at the temples, and at the base of the skull. Let's map this biology onto the actual timeline of someone's life.
Okay.
How does this mechanical compression change depending on what stage of life a patient is in?
Well, according to Dr. Lowenstein's document, there are 3 main hormonal windows across the lifespan where this mechanical compression becomes highly evident.
Let's start with the first one.
The first is the one most people are familiar with, the classic menstrual migraine. This is driven by that sharp estrogen drop about 2 to 3 days before menstruation begins.
So this one is highly predictable. I mean, a patient can look at a calendar, track their cycle, and know exactly when the swelling is going to hit.
Exactly. It features moderate reactive vasodilation in the scalp vessels and very high classic premenstrual fluid retention. Because the hormone cycle is regular, the pain reliably hits those frontal or occipital trigger sites every single month on schedule.
Clockwork.
But the second window is quite different, and that's the postpartum period right after childbirth.
Oh, right. Because the hormone drop there isn't just a monthly dip, it's an absolute cliff.
It is an abrupt, massive decline in both estrogen and progesterone. During pregnancy, the body retains an immense volume of extra fluid and blood.
A huge amount.
After childbirth, you have a very rapid shift in vascular tone and huge physiological fluid shifts as the body mobilizes and tries to shed all that pregnancy fluid.
So the sheer volume is just overwhelming the tunnels.
Exactly. Because the magnitude of the hormone drop is so extreme and the fluid volume is so high, postpartum headaches are often the most severe presentation of this mechanical squeezing.
That makes total physiological sense given the amount of water weight shifting around.
It does.
But then we get to the third window, which I think is where a lot of patients feel incredibly frustrated and, quite frankly, isolated. Perimenopause.
Yes. Perimenopause is characterized by erratic, highly unpredictable estrogen fluctuations that can last for months or even years.
It's a roller coaster.
You have intense vasomotor instability. Think of the sudden vasodilation that causes hot flashes and highly variable fluid retention that just doesn't follow any set schedule.
I can imagine someone in perimenopause thinking they suddenly have a brand new neurological disease.
Oh, absolutely.
Because it's no longer tied to a predictable monthly calendar.
Yeah.
Like 1 week you're fine, the next you have a throbbing occipital headache for 3 days, then nothing for a month, then a forehead headache.
A pattern disappears.
Right. Without the calendar to anchor them, how do they even know it's still a hormone-related migraine? The emotional toll of that unpredictability of, like, not trusting your own body must be exhausting.
It is. And if we connect this to the bigger picture, it explains why just keeping a basic headache diary based on dates isn't always enough, especially later in life.
Dates aren't helpful if the dates are random.
Exactly. This is why tracking your symptom sites specifically is far more telling than just tracking the calendar during erratic life stages.
Okay, so mapping where it hurts, not when.
Right. If the pain is consistently localized to that specific spot over the right eyebrow, or that exact trigger point at the base of the skull, that site-specific pain points to a mechanical bottleneck.
That is such a good point.
It's the location that gives away the diagnosis, regardless of how chaotic the hormonal timing has become.
That totally reframes how a patient should track their symptoms. Instead of looking at the date, map the exact square inch of the pain.
Yes, exactly.
Okay, but this brings up a really crucial turning point in this discussion. If hormones are the initial trigger causing the swelling,
Right.
shouldn't giving the patient hormone-stabilizing pills just fix the problem entirely?
It's the logical assumption. And to be clear, hormonal stabilization, things like continuous birth control, estrogen patches, or hormone replacement therapy, is a very good first step.
It calms things down.
For a lot of people, smoothing out that chemical trigger reduces the fluid retention enough to relieve the pressure on the nerve.
But not for everyone.
No. For many others, the pain stubbornly persists. And understanding why requires us to look at the long-term physical consequences of chronic nerve compression.
Because we aren't just talking about one single swelling event that happens once. We're talking about years of an ongoing cycle.
Exactly. Years of repeated hormonal cycling. Imagine years of that tissue swelling, crushing the nerve, and then retreating over and over again.
That's a lot of wear and tear.
The body responds to friction and pressure. Eventually, the anatomic tunnel itself responds to all that chronic inflammation by developing permanent tightness. It's thickening the fascia or creating actual scar tissue around the nerve.
So it's kind of like if you wear a really tight pair of shoes, it gives you a blister every single month for 10 years.
Okay.
Eventually, your foot stops just getting a blister and builds up a permanent thick callus. Even if you completely stop wearing those tight shoes or, you stabilize the hormones in our case.
You still have the callus.
Right. You still have this tough, tight callus left behind on your foot that hurts every time you walk.
That is a perfect analogy. The trigger, the hormone fluctuation, or the tight shoe might be entirely smoothed out by medication, but the physical damage, the scarred, thickened tunnel left behind, remains.
The space is just gone.
The space is permanently narrowed, so the nerve is still trapped.
Which perfectly explains why a patient might go on continuous birth control, or HRT, and they report back to their doctor like, well, my headaches are maybe a little less frequent, but they definitely didn't go away, and it still throbs in this exact same spot above my eye.
Yes, and Dr. Lowenstein points out several clinical diagnostic clues that signal this structural mechanical component is still at play.
What are the clues?
The first is site-specific pain rather than a diffuse whole headache. The second is headaches that persist despite aggressive hormone therapy.
Makes sense.
Third is visible puffiness around the eyes. And finally, a pattern that grows less tied to the calendar over time, precisely because that permanent callus or scar tissue is now the main problem.
Because it requires less and less swelling to trigger the pain.
Exactly.
So if a patient has these clues and they suspect a permanent bottleneck, how does a doctor know for sure? I mean, you can't exactly see a microscopic scarred tunnel on a standard MRI, right?
No, usually you can't.
So how do you prove it's the physical tunnel causing the pain and not just the brain chemistry?
The clinical smoking gun is a diagnostic nerve block.
What's that?
A physician will inject a tiny amount of local anesthetic directly into that specific trigger point, say right into the muscle at the superorbital notch.
Oh, wow.
If the patient experiences a temporary but significant relief of their headache within minutes, it proves the peripheral nerve itself is generating the pain at that exact physical location.
Because the numbing agent turned the nerve off and the pain stopped. So if a patient has been left with this permanent scarred bottleneck, well, a pill isn't going to fix that. You can't medicate away a physical scar. What is the structural fix?
Which brings us to the ultimate solution outlined in this document: peripheral nerve decompression surgery.
Surgery.
Yes, this procedure completely bypasses the chemistry and directly addresses the anatomy. It is typically an outpatient procedure done under sedation or general anesthesia.
Okay, so you're not in the hospital for days.
No, you go home the same day. The surgeon literally goes in and physically releases the muscle, the tight fascia, or untangles the vascular structures that are compressing the affected nerves.
So what does this all mean? They're essentially clearing out the bottleneck,
Right.
They go to the superorbital notch and widen the exit, or they go to the base of the skull and separate that throbbing occipital artery from the nerve.
Precisely. Now, I should probably throw in a quick disclaimer here, as always.
Yeah, please do.
We are discussing this for general educational purposes. Individual candidacy and surgical outcomes vary, and anyone dealing with chronic pain should, of course, consult a board-certified specialist to see if surgical or non-surgical options are right for them.
Standard medical disclaimer, but very important.
Yes. But generally, candidacy for this specific surgery requires a chronic history of headaches, imaging that rules out other structural causes like tumors, a failed trial of conservative and hormone therapies, and critically, a positive response to those diagnostic nerve blocks or targeted Botox.
Okay, so just to be totally clear on the outcome, having this decompression surgery doesn't stop your normal hormonal cycle, right?
No, not at all.
You still get the normal physiological fluid retention and the vascular changes every month.
You've got it exactly. The hormonal swelling still happens. Your body still retains some water before your period or during perimenopause.
Right.
But because the surgeon went in and gave the nerve a little extra breathing room by releasing that tight fascia, all that fluid just expands harmlessly.
Because the wall of the tunnel isn't there to crush it anymore.
Exactly. The painful mechanical consequence of that swelling is completely neutralized. The bottleneck is gone, so the nerve doesn't get pinched.
Man, that fundamentally reframes the entire condition. To think of a cycle-driven migraine, not just as some, mysterious cloud of brain chemicals we have to endure, but as a trapped nerve physically crying out for space.
It's a huge shift.
We've gone on quite a journey today, moving from a purely chemical understanding of hormone-related migraines to a heavily mechanical physical one.
We really have.
If you were listening to this and dealing with site-specific, cycle-driven pain, it might not just be in your head, figuratively speaking. It might quite literally be a pinched nerve in your head.
It's a vital shift in perspective. When we recognize that hormones influence the physical architecture of our tissues just as much as our internal chemistry, we empower patients.
It gives them a new path.
It opens up entirely new, tangible avenues for finding relief.
And we're going to end today's deep dive with a lingering question for you to ponder on your own.
A little food for thought.
Yeah. If our bodies can physically adapt to internal chemical cycles by building up scar tissue and tightness around the tiny nerves in our forehead and neck,
Which we now know happens.
right, what other unexplained chronic daily pains in the human body might just be microscopic mechanical bottlenecks hiding behind a chemical label?
Oh, that's a great question. It makes you wonder how many other anatomical mysteries are just waiting for us to look closely enough at the structural details.
It really does. Thank you for joining us on this deep dive. Keep questioning those assumptions, keep looking for the physical roots of things, and keep exploring the incredible mechanics of your own body. We'll catch you next time.
Take care.
Remember, whether it's a broken arm on an X-ray or a swollen nerve hiding in a fascial tunnel. Wait, no ellipses. I mean, whether it's a broken arm on an X-ray or a swollen nerve hiding in a fascial tunnel sometimes, you just have to know exactly where to look for the jagged line.
That's all for today's episode. Thank you for listening. If you or someone you love is living with chronic headaches or migraines and hasn't found relief through medication or other treatments, know that outpatient surgical options exist for chronic migraine, occipital neuralgia, and other headache diagnoses. To learn more or schedule a consultation, call Dr. Lowenstein's office at 805-969-9004 or visit headachesurgery.com. Please don't forget to rate our podcasts so others can find us and learn about chronic headache relief options. Thanks again for tuning in, and we'll see you next time.